Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if we'll move to the first slide, we'll start with the big one. So ONC has put out a proposed rule. It came out yesterday. It will officially post in the Federal Register next week on April 18th. The comment period will run through June 20th. We will most likely comment on the rule. More on that moving forward. Most provisions go into effect on January 1st, 2025. So the official name of the rule is Health Data Technology and Interoperability, Certification Program Updates, Algorithm Transparency, and Information Sharing. They're calling it HTI-1 for short. And it basically has 3 major categories of things, as well as some RFIs. So there's some certification criteria changes and additions. So one of the big ones is that they're proposing to make US CDI version 3 the baseline standard for certification. Note that the US core version that's equivalent to US CDI version 3 has not actually been released yet, although it is in process and should be coming soon. They are also proposing some HL7 standards for electronic case reporting, and they explicitly call out both CDA and FHIR standards. There are updates to a variety of standards and versions of standards, implementation guides, bulk FHIR, smart on FHIR, a bunch of different things. So those, we're going to delve into those more when we look at the rules in more detail. A big area is that they've revised their CDS support requirements, and they've changed the name of the CDS certification to DSI, which I spell out on the next slide. I think it's decision support. I can't remember what the I stands for. But in any case, they've changed the name from CDS to DSI, and there's definitely an area of focus. They also have some new requirements around revoking access privileges. They have some new patient privacy restriction requirements, and I have not read the actual rule yet. It's 556 pages. It came out yesterday. So this is all based on ONC, overview information, fact sheets, press releases, etc. So I did find one place where they went into a little bit more detail about that, and we'll cover that on an upcoming slide. But I actually think those are good things. And then they also are making some additions and changes to the demographics data requirements. So any questions about those components? All right, let's move on to the next slide. We have 3 slides on the rule. So they also made some changes to what they split out the certification criteria and the certification program. So one thing that they've done is they've created a bunch, around 10 or so, of health IT quality measures. And you may remember, for those of you who've been part of the DGC for a while, we had some meetings where we talked about quality measures for the EHRs, and that's what these are. So these are measures that the EHR vendors do to assess how well their the usage of different pieces of the certification and stuff like that. We're not going to go into that in more detail today, but we'll look at those in more detail in the future. They're just also changing the way they name the certification requirements, getting rid of the year themes. They are also requiring that you can only certify against the most recent certification criteria. So they're no longer, in the past, you could, to some extent, choose what to certify against. And there were certain areas where you didn't have to, where there were multiple versions of the certification criteria, and you could pick different ones. Moving forward, you will always have to certify against the most current version. And all of the certification requirements require that the related functionality be fully available to customers by a certain date. So if you're supposed to be certified by X date, that certification includes not just having gone through the formal certification process, but that functionality that you're certifying has to actually be available and in use, and customers can use it at that time. And that's similar to what they did for the FHIR APIs that were in December of 2022. So that's not surprising, but it is a change and they're making that consistent. They're also, and this is also a really good change that I'm in favor of, going to require a standard format for base URLs for API endpoints. That means that there will be a way to determine what the base, what the base URL means by looking at the URL. Very, very good move. Haven't seen the specifics of it, so I can't comment on exactly what they're proposing, but that's a good thing to impose. So, and then the other component was information blocking rules. And I will tell you that the overviews of these were a little bit confusing. So we'll probably have to wait until we go into the details that are in the rule itself to fully digest what this means. But one of the things that they did was they narrowed the definition of vendor a little bit, and they didn't provide specifics in the pieces that I read. They also explicitly excluded providers who develop their own certified health IT for solely their own use from the definition of health IT developers. But this is within the context of information blocking rules. So I don't understand the point of that, because they're still subject to information blocking, the same information blocking rules as providers. So it wasn't clear to me why they made that point so clearly, and why that's important, because whether you're a vendor or you're a provider, you're still a valid actor for information blocking and the rules still apply to you. So they also provided some clarification of some existing exceptions. What I mean is the rule provides some clarification. They didn't see a lot of the clarification. And there are a couple of new exceptions or new components of existing exceptions. So one of the things that they called out as new was an exception for when third parties are seeking modification, and it was not well spelled out again in the pieces that I saw. And they also made a note that it doesn't apply to all cases. So we'll have to look at that in more detail later. The next one is kind of just an obvious logical extension of the existing rules, which is a manner exception exhausted condition. You may remember that one of the information blocking exceptions is that the person who's making the request gets to request a format, and then the person who has to fulfill the request can say, I can't do that format, and then there's the negotiation process for what the format should be. So what this is saying is just that we've gone through the entire negotiation process and we never settled on anything that was satisfactory to both sides. Therefore, that's now, as long as that's done in good faith, under some limited circumstances, that's now an acceptable reason to not share the information. And then there are also some TEFCA related manner exceptions. And again, didn't see a lot of detail yet. And there was an interesting point in the comments, and I don't know, Kate, but which says that there might be different penalty structures. And that's actually a really good point, because technically speaking, the formal penalties have not been announced for information blocking. There's a pending rule that's still in the still out there for 2023, expected later in 2023 publication, which is outlining the penalty structure for information blocking. So it is possible that there are different penalties, and that's why it matters. Good call. Any other comments or thoughts here? All right, let's go to the third slide where there's a few more details about a couple of things. So Decision support interventions, that's what the I stands for. So one of the big goals, and again, they didn't supply any details in the overview things that I saw, but one of the big things that they're trying to do with the new DSI stuff, which again was what was formerly the CDS stuff, is to improve transparency and also support more consistent use, particularly in AI, with different algorithms and models and other forms of AI. So I don't know the details, but folks who've been at the DGC for a while may remember that the ONC had some listening sessions around what type of regulation we'd like for AI or thought made sense for AI. What we'd like is maybe not the right phrasing, but what we thought made sense. And it's possible that this set of stuff is an outcropping of that outreach, both the one I participated in and others that were similar. So we'll see what they do there when we read the full rule. Now, this is the part I mentioned, the privacy model. I found one mention, and this is really good. So the new privacy model that they're proposing be part of certification is that providers can flag certain parts of USCDI data as restricted from subsequent use or disclosure, meaning that even though USCDI is meant to be the baseline exchange requirement, certain things can be flagged as do not share. I think this is really good, particularly in hand with a move to USCDI version 3, because this would mean that all SUH data is part of USCDI version 3. And that's an area where we've had a lot of discussion that patients in particular feel that should be considered more sensitive data and should require more consent than other data for sharing. And technically it doesn't, but this would be a mechanism for allowing some of that. And also there might other conversations we've had in that area around some patients only being comfortable sharing their gender identity with certain providers, or sharing the fact that they're trans, or sharing certain elements like that. So obviously we'll have to see how it's written and what it actually does, but I see the potential for that solving those problems. Now I will point out that this is only on the ONC side and only for certification. There would need to be some type of corresponding mechanism on the CMS side to say that the same type of privacy toggles are supported, and otherwise the requirement on CMS is that you share all of the USCDI data. Right now it's at version 1, but when the CMS stuff moves up to version 3, then there's a potential incompatibility here. So this is something we'll have to keep an eye on, but in general, that's, I think, a good move. Also in keeping with privacy stuff, there's a requirement that certified health IT must be able to revoke third-party app access to a patient's data within 1 hour of getting a request to do so. So that actually is both a really long time and a really short time. It's an interesting time choice. On one hand, if there's some type of automated process, that's an awfully long time. And if you're not relying on that, then it's a really short time. So it'll be interesting to see how that ends up resolving itself too. And then one of the other things they called out that was really interesting, and again, some of these bits and pieces were kind of buried in one place, and I don't necessarily have a ton of exact detail about it yet, but the demographics changes that they mentioned, excuse me, would mostly align with USCDI version 3, but they also specifically call out a requirement to support pronouns and a name to use type field. Neither of those are currently in USCDI. They're not even proposed in USCDI draft 4, although perhaps they'll show up in the final version. They were discussed as things that they were considering in a previous version of USCDI. So there was discussion in one of the bulletins related to a previous USCDI update about investigating whether it makes sense to add pronouns and how they should be added if we do that, etc. So it's possible that, for those of you who haven't necessarily gone through this. The USCDI draft versions are often drastically different from the final versions of the same number. So there's no reason to think that there won't be, it's very possible that there would be additional pieces, including those pieces, in the final version of USCDI 4. But again, pointing out this regulation actually only requires version 3. So that's kind of a really quick and dirty overview. Again, have not actually read anything in the actual rule itself yet. That will be coming, and we'll delve into all of that probably over the course of several meetings. But here's kind of an overview. You can find a fact sheet, one of the fact sheets I used, and the rule itself. There's a whole bunch of different sheets. Each of the quality measures actually has a fact sheet which describes the quality measure. So if you're interested in those, you can go to the ONC website and find those as well. Any initial thoughts, comments based on what we know now? All right, well, there'll certainly be more about this in future meetings. Moving on then. So CMS put out a final rule for Medicare Advantage, Medicare Part D, and PACE, which is a dual eligible program for elderly folks. That's effective for 2024 year. That includes some prior authorization changes. And it's interesting because it includes some of the things that they did not put into the interoperability and prior auth rule that were suggested and that we suggested in our comments. For instance, the 90-day continuity of care requirement. So this rule says that if you have a Medicare Advantage or if you're doing Medicare Part D or PACE, that you have to continue, if there's a prior auth from an old plan, you have to honor it for the first 90 days that the person is enrolled in your plan. All that a new plan is allowed to do is confirm diagnoses and that treatment was deemed medically necessary within the database that CMS has around prior auths. So another thing that they did was they said that plans have to strictly follow the Medicare rules and guidelines for utilization and coverage approvals. So you can't, if you're running a Medicare Advantage program, you can't create your own prior auth rules. You have to follow the Medicare rules and uniformly follow what Medicare says for those programs. And then the last piece of it that was prior auth related is that you're supposed to make an attempt to grant prior authorization for an entire course of treatment at the start of the treatment. So, and they explicitly call out that while you can take into account, while you should take into account your plan maximums, you also have to take into account the individual patient's medical history and provider recommendations. For instance, let's talk about physical therapy for a second, since we've been talking about that recently. You could have a plan which allows 60 visits per year, but it's pretty common. You might say you can have 8 visits to start, and then you can request more if you think they're needed. But if the initial recommendation was for 20 visits, it's under the 60 visits that are allowed, and they can provide some documentation around why they think 20 visits is the right thing to do. Then then in theory, you're supposed to accept the 20 visits. I mean, or at least look at that, consider that as a whole and not assume that it will be 8 visits and then we'll give you 8 more. And then if you still need them, we'll give you 4 more. That doesn't mean it'll exactly match what you end up needing, but the idea is to try to take all of that into account so that you get it right the first time. Any questions or comments about any of those 3 criteria? You can find a copy of the rule at that link, and we'll move on to the next slide if there are no comments. So another thing that came out this week is there are 2 new TUFCA draft standard operating procedure documents. One of them covers risk adjustment, and the other one covers what they call limited exchange. So the basically the limited exchange is healthcare operations, is non-treatment functions for healthcare operations. Quality assessments, care management, patient safety, population-based activities are some of the ones that they call out. But they're basically non-treatment functions that fall under operations as opposed to payments or one of the other areas that they explicitly have separately. So they give 30 days for comments. So these have any comments, they're very short documents. Any comments that you want to submit have to be out by May 3rd. We'll take another look at them, but there's links to both of them on the slide. Any questions? All right, let's move on then. All right, so I think this got mentioned last week when we talked about some of the AI churn in the media, but the Coalition for Health AI has put out their blueprint for trustworthy AI in healthcare. You can find the full document at the link below. But what it basically talks about is that it splits up things that it thinks AI should be required to conform to into these 7 areas that are listed. And they talk about some of the components under a few of them at a high level. There's more detail about all of these in the document, obviously. And then they have a section that talks about what some of the next steps should be. This is only a subset of the things they recommend there, but they talk about having AI registries and more standardization and sandboxes for playing around with the algorithms and figuring out if they meet your needs and a few other things like that. So you can find the whole full report at that link. Any questions or comments? All right, let's go on to the next slide. So this one was interesting. So CLAS and the Arch Collaborative put out a report on the keys to EHR user satisfaction. And what they did was they talked to a whole bunch of people who said that they're satisfied with their EHRs. And they compared their answers to a bunch of different questions to people who are less satisfied with their EHRs. And some of these are kind of no-brainers, but what they basically found was that most of them felt like they were trained really well. The majority of them thought that they had a good implementation that was put together with their needs in mind. And although this is actually the lowest number, this is the one that was stressed the most in the report overview that I read, which is that likely to personalize the EHR. That was seen as one of the big keys to being satisfied. It's between 27 and 30% of the people who when asked, said that they think they're more satisfied than other users because they're taking a lot of personal initiative to learn about the EHR and to seek out answers when they have questions. And that was similar, like it ranged between 27 and 30% across different populations that they talked to. I think nurses were at 30. I think it was 27% generally. But they basically, that was the overwhelming, the overwhelmingly most popular answer to why do you think you're more satisfied with your EHR than other users? And I should note that the people who took part in this all used athenahealth, Meditech, Epic, or Cerner. So you can find an overview of the report and a link to the full report at that URL if you're interested in looking at this further. Any comments or thoughts there? All right, then let's move on. So this also has a bunch of no-brainers, but HC3, which is the Health Sector Cybersecurity Coordination Center, which is one of the several cybersecurity groups within HHS, has put out a bunch of recommendations for mobile device security. And what they've basically said is lock down your device. That's pretty much the advice, is lock down your device. Disable all connections that aren't actively being used, limit your connectivity, be careful about where you use Wi-Fi, pay attention to the actual routers and devices that are being used to serve Wi-Fi when you use it, install as few applications as possible, install all the security updates immediately, use multi-factor authentication, use lock screens, use other security features, use encryption, install remote monitoring, remote wiping, and have some inventory tracking. So the last two are really enterprise related. The others were more general, but it basically, there's always a war between the more you lock down the device, the less useful it is. And especially with so many things storing data in the cloud these days, it's really a bigger balance even than it used to be. So I don't know how useful all of this advice actually is, because it's kind of like, yes, we can lock everything down completely, and then we can't do anything with the device. So what's the point? But be that as it may, that's sort of what they recommended. And obviously, you know, with some balance, none of them are bad suggestions, but I think that they just need to be balanced a little bit with what it is you're trying to accomplish with the device. And know that there's always risk with any connected device of any sort. So the question is, what's the right balance between the risk versus the reward of using the device and getting the benefit from what you're trying to do? So anyone else want to comment on any of that? All right, then let's move on. If you'll pause there for a moment. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That email address is also on your screen.